Well, thanks very much for the opportunity to participate in this important discussion. My task this afternoon is really to set up the discussion, I think, not by answering the questions put before us, but by laying out a theoretical framework in which we might address those questions productively. The framework I'm going to put forth is one called component analysis. So let's start with what's that? Component analysis, which many of you would have heard of and some of you may have worked with, is a systematic and comprehensive approach to the ethical analysis of research benefits and harms. It's a refinement of the risk framework developed by the National Commission and its report on IRBs and also in the Belmont Report. As these documents served as the basis for the common rule, component analysis usefully serves as a basis for the interpretation of the common rule. There are a number of publications that I might direct you to. I think the shortest one is one in Nature Medicine from 2004. I'm going to talk today about a full view of component analysis. Often we only focus in on what I'm going to call the second step of component analysis, but today, because of the question that we're facing, I'm going to talk about the full sort of approach to it, and this involves two steps, not just one. In the first step goes like this. If the protocol relies upon the presence of standard therapy, separate standard therapy from research interventions. Now, why would you do that? The reason is actually simple, and that is that the purview of the IRB is limited to overseeing research interventions. Standard therapy falls under the governance of the doctor-patient relationship. We'll say more about that. The second step of component analysis is for the IRB to focus in on these research interventions and to separate therapeutic procedures from non-therapeutic procedures. The reason to do that is there are distinct ethical analyses required for each type of research procedure. And as I've suggested, in many publications, it's only this second step of component analysis that's focused upon. So let's go into a little more detail on each of these two steps. The first step, as I've said, involves separating standard therapy from research interventions. The reason is that it's only research interventions that fall properly under the purview of the Institutional Review Board and federal regulations. Ordinary therapeutic practice is managed within the physician-patient relationship. It's ruled by professional norms. Treatment here is the product of joint deliberation and agreement between patient and physician. Well, there's a difficult question about what we ought to consider as counting as standard therapy, in part because in practice standard therapies may be diverse. But the definition of standard therapy is fairly clear, and that is namely treatment accepted by at least a respectable minority of expert practitioners. So that's the first step in component analysis. Separate out standard therapy and from research interventions, and then in its deliberations, the IRB is going to focus in on those research interventions. In the second step of component analysis, the IRB needs to separate therapeutic procedures from non-therapeutic procedures. Therapeutic procedures are those that are administered basically with therapeutic warrant. That is, on the basis of evidence sufficient to justify the belief that they may benefit research subjects. These procedures need to be assessed and found consistent with the requirements of clinical equipoise, basically requiring that there be some rough parity between these procedures and competent medical care. Non-therapeutic procedures, on the other hand, are not administered with therapeutic warrant. They're administered solely for the purpose of answering the scientific question at hand. And here there are different sorts of moral requirements. Risks must be minimized, consistent with sound scientific design, and they need to stand in reasonable relation to the knowledge to be gained. So we can look at this second step in the form of a flow diagram. And in this, the IRB here, as I've said, separates therapeutic procedures from non-therapeutic procedures. Therapeutic procedures must fulfill the requirement of clinical equipoise. Non-therapeutic procedures must have their risks minimized and have those risks deemed reasonable in relation to the knowledge to be gained. Importantly, according to this view, minimal risk as a risk threshold actually only applies to non-therapeutic procedures. Finally, the requirements for therapeutic procedures and non-therapeutic procedures must both independently be fulfilled in order for an IRB to be able to responsibly conclude that a study poses benefits that stand in reasonable relation to the risks to individuals. So, that's component analysis. Let me now consider two examples and talk through how component analysis might think about these examples. Study A is an observational study, and what we're going to do is look at two types of patients in clinical practice. The first group of patients are patients for whom their physician has prescribed treatment A, and the second group are those for whom their physician has prescribed treatment B, both for the same medical condition. We are going to do some assessments. We're going to assess the patients at baseline, and we're going to assess outcomes. Okay? That's study A. Study B is similar in some respects to study A, but rather than being an observational study, it's a randomized controlled trial. It starts with the same group of patients, patients who in clinical practice might be prescribed by their physicians either treatment A or treatment B. And what we're going to do to these patients is we're going to randomize them, not too surprisingly, to treatment A or treatment B. Okay? We're going to do some baseline assessments and outcome assessments on patients in these studies. I take it that really the question before us today, and the question that I take it as sort of the deep question in this debate, is to what degree should researchers, IRBs, and regulators treat these two studies as more or less the same? Or can we articulate morally relevant differences between these two studies that suggest that in fact we should treat study B differently than we should study A? I think component analysis frames that question for us nicely, and let me take you through how it would think about each of these two studies. So let's start with study A, the observational study. As I've said, step one in component analysis is to separate standard therapy from research interventions. In this case, we've said that, well, physician-prescribed treatments are involved, and by definition, physician-prescribed treatments are standard therapy. So according to the first step of component analysis, in fact, treatment A and treatment B here are demarcated out of the picture. All right? That means, going into step two, the IRB is only going to be focusing on research interventions. It needs to look at these research interventions and separate therapeutic procedures from non-therapeutic procedures. It turns out in this case that's pretty easy because there are no therapeutic procedures. And the IRB's sole task here is to ensure that the non-therapeutic procedures fulfill the various requirements. And I take it, actually, in everything that I've read about this debate, nobody disagrees about this picture of study A. So then, what about study B? Well, so step one here is to separate standard interventions, standard therapy, from research interventions. Here's where we get into, I think, conflict about how to think about things. There are two views about how to do this correctly. All right? Let me present one view, and then I'll present the other view. Here's the first view. The first view says, look, treatments A and B fall within the standard of care, and thus they are standard therapies and are properly regulated by the doctor-patient relationship and the norms associated with it. Therefore, treatments A and B ought to be demarcated out of the picture in step 1 of component analysis, and as they are not research interventions, they do not fall within the purview of the IRB. Right? So out they go, right? And this then, what remains now, is what goes to the IRB properly for its consideration and also for inclusion in the consent form and so on. There's disagreement about whether this is the right view. So let me present a second view of how to do step 1 with regard to this study. So here's the second view. The second view says, no, wait a minute, that's not quite right. In fact, treatment A and B do not fall, should not be viewed as falling under the norms of the doctor-patient relationship. Why? Because there are morally relevant differences between the setup in study A and what we find here, the context in study B. Well, what might those morally relevant differences be? Well, these treatments are assigned randomly. Well, we have to say more than that. That's not enough. Neither, if a particular patient receives treatment A in this study, it is not the result of a physician recommendation, nor is it the result of a consideration of a series of treatment alternatives and then a reflection upon that patient's values and the patient deciding this is the right treatment for me. In other words, it's not the product of joint deliberation and agreement between patient and physician, and therefore these treatments ought to be considered research interventions. Okay? So those are the two views, and I'm hoping what will happen in our discussion with this panel in part is that people will argue for which of those views they think is right. I see I'm a little bit over time here. Let me just conclude with a couple of thoughts. The first is that even if we hold the second view to be correct, the harm-benefit analysis undertaken by the IRB in this case, I think, is actually incredibly straightforward. The therapeutic procedures here, according to this second view, include treatments A and B, and it seems to me these straightforwardly satisfy clinical equipoise in almost any case. The non-therapeutic procedures only involve randomization and outcome assessment, and the usual sort of IRBs tasks apply there. So I think actually the difficult questions here are not at all in terms of the standard IRB harm-benefit considerations. They're really in terms of step 1 in component analysis. My last slide, let me say something about informed consent. Here, I think whatever one's view, one should hold that moral informed consent requires that subjects be informed clearly of the study purpose. I think moral informed consent, as opposed to, say, what one might call regulatory informed consent, should require an emphasis on the implications of participating in the study and declining participation. First and foremost, the question that needs to be answered for prospective participants is, what difference will study participation make to me? Finally, I would say that with regard to these studies, even if standard of care RCTs pose minimal risk, I think generally, in fact, a waiver of consent is not appropriate for these studies. Okay, thanks very much.